Okay, so we're gonna do this evening. We're gonna do some revisions. Okay, so revision in gastroenterology and hepatology, and we're gonna do a kind of a discussions, a question answers, and things like that. Okay, so I won't give you lectures. Okay, we're just gonna have some discussions. If you have any topics you want to talk to discuss, you can say it. Okay, we can discuss it as well. Okay, so I will start first with the first topic that I want to discuss today about the GI bleeding. Okay, so this topic is very, very important. You'll be asked this over and over again, either in your exams or when you be a doctors as housemen, or even when you are medical officers. Okay, these are questions that will be asked again and again for you. Okay, we talk about a case that I got yesterday. Okay, yesterday I got a patient, a 70 years old man with history of triple vessel coronary artery disease. Somehow, somewhat, he got the PCI last month and be put on dual antiplatelet therapies. And he came 2 days ago with fresh melena, okay, with upper GI bleeding. Okay, so I'm going to ask you a question that I asked the medical officer who referred to me. Okay, what do you think is the cause of the bleeding? What would be the diagnosis? Very simple and straightforward.
Doctor, may I try?
Okay,
I'm
please.
thinking of bleeding peptic ulcer disease secondary to prolonged aspirin usage.
Okay. There is a very simple and straightforward, isn't it? Okay, it's usually a peptic ulcer disease. And when you talk about peptic ulcer disease, it's one of the commonest cause of upper GI bleeding. Usually, the peptic ulcer is caused by medication, as in this case, aspirin, sometimes NSAID, sometimes steroid, or some traditional medication, etc., etc. Number 2 cause of peptic ulcer disease would be the infection, the H. pylori infections. And a rare cause of peptic ulcer disease is like gastrin-producing tumor, Zollinger Ellison. Okay, so usually when you talk about peptic ulcer disease, that will be the causes of peptic ulcer disease. Okay, so these patients come to you with upper GI bleeding. What were you gonna do? You are the doctors in charge, seeing this patient emergency department. What do you like to do with the patients?
I'm going to take the history of the patient.
Yeah, okay, fine.
I want to know more about the GI bleeding, because the melena, and also if there is also any vomiting of blood, because I want to know the severity, the current condition of the patient, to stabilize the patient if there is any hypotension, for example, and the quantity of the blood itself. Is there any associated with any blood clot as well? That may indicate severe and large volume of bleeding. So by that, if I clinically, if I suspect that it is severe, and clinically the patient looks unwell, looks hypotension, looks dizziness, and has symptoms of anemia as well, so I will stabilize the patient, prepare 2 large bore cannula, take the JXM, and get ready for the blood transfusion. And before that, I start with IV crystalloid first. Okay. And then I start to investigate the causes for it, which is most likely the peptic ulcer.
Okay, fine. Okay, all right. Of course, we're talking about history and examinations when we see the patient, isn't it? And when you say about the history, mainly what you're gonna ask in general is that what are the history of the bleeding itself, and you want to know past medical history and history that lead to bleeding tendencies. You want to ask the patients about medication, like this patient we have already knows the patient take two antiplatelet therapy, sometimes patient take anticoagulation, etc., etc. Okay. But the first thing that very important for you determine in this patient is that how bad is the bleeding, isn't it? Okay, how bad is the bleeding? Okay, we already know from the initial history this patient have a GI bleeding due to aspirin. So what we want to determine now, how bad is the bleeding? Okay, and this you can know by asking how many times the patient have a hematemesis, a fresh melena, for how long, and you look for hemodynamic instabilities. Okay, the blood pressure is very important. The heart rate, is the patient tachycardic, is the patient have sign of shock, cold peripheries, and okay, so is a patient palest and things like that. Okay, and then when you assess this, what you're gonna do is you need to manage the bleeding. Okay, so just now you say part of the management, but when you talk about patient with the bleeding, you will talk about how you gonna stop the bleeding and how you're gonna replace the blood loss, isn't it? Okay, so for this patient just now, you say a few things about stabilize the patient. That's very important. You say about a blood transfusions, that is important. But how you're going to stop the bleeding?
Can I try?
Yeah.
Okay. We need for patients that have continuously bleeding, we need to stop the bleeding by doing the endoscopy within 24 hours, which is urgent endoscopy. And then we look at the site of the hemorrhage and we assess the hemorrhage. Is it a major stigmata with an hemorrhage or minor stigmata with an hemorrhage by forest.
Okay.
And then by that we decide what kind of method we want to do to stop the bleeding. Okay, for the major stigmata of nasal hemorrhage, we do a dual therapy, which is it either by mechanical, by injection, or by thermine. Okay. So,
Okay.
I go on. Okay. So if mechanical, we can do clips, and then if by injection, we can inject the adrenaline. And then the other one is the thermine. We use the thermal probe to stop the bleeding. And then we also, after the dual therapy, since the bleeding stop, we need to give patient IV pantoprazole within for 72 hours. Okay. For epithelialization to take place. And then we reassess patient if there is any bleeding or no.
Okay. Anything else?
That's for the current. Do I need to proceed to?
Okay, fine. I think that's very good. Okay, so first of all, as you said, the patients have on dual antiplatelet therapies. Okay, so what I like to do first before we do the invasive intervention, we have to optimize the medical treatment first. Okay, you always try to do answer in that ways. Okay, the less invasive, the more invasive. Okay, so for medication wise, this patient take dual antiplatelet therapies. Okay, what do you think? Is there anything that we can offer for this patient? The platelet level is normal. Okay, fine. Okay, so have you heard about acquired platelet dysfunction? Okay, so thrombocytopenia, you know, it can cause a bleeding, but sometimes you can have a patient with normal level of platelets, but the platelet is not functioning. Okay, so platelet dysfunctions. Okay, so in this case, when you have a patient with life-threatening bleeding, you can consider to give a platelet transfusion as well as part of your management. Okay, but it's a quite still there are debates about that. Some people say not to give. Some people say is have a rule to give, etc., etc. Okay, but usually in mild bleeding or moderate bleeding, probably we won't give the platelet transfusion. But if a patient with life-threatening bleeding, I think that we should consider to give a platelet transfusion for the patient. And of course, this antiplatelet therapy should be stopped as well while the patient have active bleeding. Okay, you talk about proton pump inhibitors early on. Okay, so proton pump inhibitors is the acid suppressant that we use in treatment for peptic ulcer disease. But again, the treatments of using the PPI is also some discussions and debates about that, because in the studies, what they found out is that the use of PPI infusion prior to endoscopy does not associated with increase in reduce in mortalities, reduce in surgical intervention. Okay, so either you give or don't give PPI, the outcome will be the same prior to endoscopy. However, the PPI infusion is a very, very important as well, because it can reduce the stigmata of bleeding. Okay, for example, if I scope the patient, I don't give a PPI infusion, I may find a high stigmata of bleeding and maybe a bit difficult to control during the procedures. But by giving the PPI infusion, it can reduce the stigmata. When we see the lower stigmata of the bleeding, it's easier for the endoscopy to track the ulcers. Okay, so I do think that PPI infusion have a role and should be given in patient with peptic ulcer bleeding. Okay, another medication that I usually use is the erythromycin in the massive bleeding. Okay, because you can imagine that patient with hematemesis or life-threatening bleeding, they will have a lot of blood clot, blood in the stomach, and so on. When you scope the patients, look in the stomach will be full of the bloods. You barely can see anything. You cannot find the source of the bleeding at all. And usually, the patient needs a second procedures, and the initial procedure, basically, we cannot do anything. Okay, so erythromycin is a prokinetic, and the function of that to empty the stomach prior to procedure to ease our job when we do the endoscopy. Okay, as you see, blood transfusions, correct the coagulopathy, and all of that should be done. All right, you mentioned about endoscopy earlier on, and you say that it should be done 24 hours from the bleeding. Okay, so what we want to stress on these 24 hours is that the priority when the patient comes with the life-threatening bleeding is the resuscitation and optimal medical management. Okay, the patient don't come to emergency departments and we need to do the scope within half an hour or an hour. Okay, we have to stabilize the patient first. We have to optimize the medical management first before we scope. Okay, there are studies done, and it's look at the timing of endoscopy, and what they look at is we do the endoscopy as emergency between 12 hours compared to urgent endoscopy within 24 hours, the group that we do within 12 hours actually have a higher mortalities and poorer outcomes. Okay, maybe the outcome is poorer because when we do faster, mean the patient have more severe disease, but the study also stressed on the inadequate resuscitation in this group. Okay, because you say, oh, we're going to do the endoscopy now, so they forget about the basic about crisis resuscitation, blood transfusion, replace blood product, stabilize that, PP, etc., etc. Okay, so this is a very, very important point. Okay, because I always got called at 3 o'clock in the morning, at 4 o'clock in the morning about GI bleeding, and when I asked what have been done about the patient, they say, oh, the patient just come out from emergency department's door, they stay resuscitate the patient, they stay this the patient. Okay, so that is not the time we're going to do the endoscopy. Okay, you have to completely resuscitate the patient. Okay, so and then as you say, we're going to do an endoscopy for the patients. Okay, for endoscopy, we're going to diagnose what is the cause of the bleeding. By far, the commonest cause of the bleeding will be peptic ulcer disease, esophageal varices. Sometimes you get a fundal varices as well. But there are many other causes of GI bleeding. You know, sometimes you can get telangiectasia, hereditary telangiectasia. Sometimes you get angiodysplasia. Sometimes you can give gastric intravascular ataxias. Sometimes you can get delophil ulcers, delophil vessels. Sometimes you can get a bleeding tumor, either esophageal tumors or stomach tumors or duodenal tumors. Okay, so I'm trying to say to you here is that the cause of GI bleeding is not exclusive to peptic ulcer disease and varices alone. There are many other causes. Okay, so the endoscopy, we actually tell you what will be the diagnosis, and the treatment will be dependent on the diagnosis. Okay, there will be a specific treatment for a different conditions. Okay, but for this case, we're just going to talk about a peptic ulcer bleeding. Okay, when you talk about peptic ulcer bleeding, you have to talk about the Forest classifications of peptic ulcers. Okay, you probably learned this in your surgical attachment already. There is a Forest 1, Forest 2, and Forest 3, where Forest 3 is the mild peptic ulcer disease with a low risk of rebleeding, while the Forest 1A, 1B will be high stigmata and they have a higher risk of rebleeding. Okay, many people that I scope for upper GI bleeding, I don't see active bleeding during the endoscopy, but what I really see is that they have a high stigmata of rebleeding or not. Okay, we are talking about rebleeding. The bleeding already stopped, but will this patient develop another bleeding in the next few hours? Okay, so usually if you have Forest 2A or above, okay, 2A, 1B, 1A, that is a high stigmata and that warrant intervention. But if you have Forest 2C or Forest 3, the risk of bleeding is minimal, and usually a PPI bolus will be sufficient for these patients. Okay. If a patient high risk of stigmata, as you said earlier, we have options, and the option that we can use would be adrenaline injections. We can inject the sclerosing agent as well, and we have endoclip as a mechanical way to stop the bleeding, and we can coagulate the ulcer with the trauma probe as well. Okay, so there are a few modalities. I don't think you need to know in details, but as long as you know what the options, and you need to use dual therapy, and that will be sufficient. Okay, so let's say this patient have forest chew a ulcer in gastric and get endoscopy, and we clip and we inject the patient with adrenaline. But the patient have keep bleeding and bleeding and bleeding. What are the options that you can do for the patients? Okay, what I'm saying, the patient fail endoscopy interventions now. Okay, what are the options to treat?
May I try? We can repeat another scope, but if it still fail, we can consider of radiological intervention by embolization through CT.
Okay, what else?
What else? I don't know anymore.
May I try?
Okay, fine. Yeah, sure.
And if the bleeding is progressive and cannot be stopped, we may also consider a method like, for example, using second black tube, where the principle is that we want to compress the bleeding site by we inflate the balloon, and we insert light entry tube, and then we inflate the balloon and compress the bleeding site in order to stop the bleeding. And
okay, fine. Okay. Okay, first about the second blood tube. Okay, as I told you that the GI bleeding can caused by many conditions, and one of them is esophageal varix. Okay, and second blood tube is not used to treat peptic ulcer disease. It's a part of treatments of esophageal varices. Okay, so if you have failed endoscopy treatments for patients with peptic ulcer disease, as your colleague said earlier on, the option is the radiological options. So what we can do something called CT, selective mesenteric angiograms. So this CT, we're gonna give a contrast, and we're gonna see the mesenteric arteries. Okay, you know from your anatomies already about this, and if the contrast is leak, okay, there is extravasations of the contrast, meaning that the contrast is leaked out of the blood vessels, you can say that the patient's bleeding here or here or here. Okay, so what the radiologists do in here in UIA, we have Professor Razali, and he can target the bleeding vessel, okay, and embolize that. Okay, you embolize that, you stop the bleeding. All right, but this embolization is a quite such specialized treatment, and not all hospital or center have the capacity to do this. Okay, so what more common than embolization is a surgical treatment. Okay, open out the patient's underrunning and possibly gastrectomy if required. Okay, so don't forget about your surgical management. In the era of PPI, endoscopy, advancement, etc., we see lesser and lesser people go for surgery for peptic ulcer disease, but now and again, people will have need to go for surgical treatments. Okay, all right. So that would be your peptic ulcer. Okay. For patient with peptic ulcer disease, after the acute episode, you have to scope the patient again after 8 weeks. Number one, we should look for H. pylori infection. Okay, usually during acute bleeding, we don't take a biopsy or investigate because we don't want to worsening the bleeding. But you have to check the patient for H. pylori. As I said, that it will be one of the causes of peptic ulcer bleeding, and you want to see the ulcer heal. Okay, because in very rarely the cancer could be the ulcer could be cancer as well. Okay, cancerous as well. So after 8 weeks of PPI treatment, you would expect the ulcer to heal. If ulcer, that's fine. Okay, but it's not healed, you have to take a biopsy to rule out a neoplasm. Okay, you can read about Zollinger-Ellison. Quite interesting to read about that, but I don't think we need to discuss about that. Okay, let's move on to another case. Okay, another case that I got last week. Okay, a patient, 39 years old man in penjara and he's was taking intravenous drug as well prior to convicted, and he also come with massive hematemesis, okay, recurrent hematemesis. Okay, what you're gonna do and what do you think would be a potential differential diagnosis in this patient?
It could be upper GI bleeding secondary to esophageal varices. Since patient had history of IBD, patient already developed a lupus, like Hep B infection, could be a liver cirrhosis, and developed portal hypertension that lead to esophageal varices.
Okay, fine. So, okay, I think you are right. Okay, so first of all, the commonest cause of GI bleeding is peptic ulcer disease. Okay, so peptic ulcer disease still should be part of your differential diagnosis. Okay, but there is history of IBDU, and especially in Pahang here, we have a lot of problem with IBDU, and usually people with IBDU, they have a risk to get viral hepatitis C, okay, not viral hepatitis B. Okay, viral hepatitis B is more common in IV drug user. Okay, and if they get chronic viral hepatitis D for quite some time, we're talking about 10 years, 15 years or something like that, they will end up with liver cirrhosis, and that will cause portal hypertension and esophageal varices, okay? But if a patient already have a liver cirrhosis, I would expect that the patient already developed signs of liver cirrhosis as well, okay? So you actually can examine the patient and look at the stigmata of chronic liver disease, okay? Finger clubbing, ulnar erythema, hepatic flat, you know, all are the stigmata of chronic liver disease, okay? Because if I ask you, oh, do the patient have stigmata of chronic liver disease? You say, oh, no, the patient have no stigmata of chronic liver disease. I might think, oh, maybe this is not varices, they can be a peptic ulcer disease, okay? So you have to establish the diagnosis, and for liver cirrhosis, you can do a clinical diagnosis. All right, so let's say for discussion's sake, the treatment will be the same as peptic ulcer disease because we still suspected a differential peptic ulcer disease. But for discussion's sake, we're just going to focus on varices. Okay, so what are you going to do with this patient now? Any different from the previous patient in terms of management?
In terms of management, it will be the same as for the first part, initial stabilization and stop the bleeding. But I think there is addition of pharmacological therapy that we can suggest, which is the terlipressin or the somatostatin. And we can also advise for antibiotic prophylaxis, which is the etc. So on.
Okay, very good. Keep going.
Can I stop here?
Yeah. Okay, fine. Okay, you already answered a few questions kan. Mana lagi kan ada 100 orang ni semua tidur ke? Tutup video lepas tu baring ke apa ni? Okay, what else you can do?
That's why I would like to try.
Yeah.
After we have given the caliprosine and antibiotic prophylaxis, we can opt for endoscopy. If endoscopy is unavailable, we may want to choose the link component if still activating. If endoscopy available, so we would like to look in detail ada esophageal or gastric varices. When we can do therapeutic such as sclerotherapy.
Okay, fine. Okay, I think I agree with you that for all GI bleeding, the most important thing is the resuscitation of patients. Okay, a blood transfusion, especially a patient with liver cirrhosis. When they have liver cirrhosis, we know that the liver functions also will be affected. Patient usually have the coagulopathy, and most of the patient will need a fresh frozen plasma infusion. Okay, but I also would like to stress to you that INR in patient liver cirrhosis is no longer a measurement for bleeding tendencies. Okay, if you have a patient with liver cirrhosis INR of 3, it doesn't mean that patient have higher bleeding tendency than normal people. Okay, and the reason of this is because we know that in liver cirrhosis there will be a low productions of the coagulation factors, but also what happened, there also a reduction in productions of pro-coagulation factors like protein C, etc., etc. So in the liver cirrhosis, they will have a new balance of hemostasis when it's no the INR is no longer a good measurement for bleeding tendencies. Okay, but when patient come with the hematemesis, there is a bleeding tendency already, and most patients will end up with factors, the fresh frozen plasma. Okay, so fresh frozen coagulopathy, correct coagulopathies. Okay, and another things about the blood transfusion I didn't mention early on is that we use a restrictive blood transfusion. Okay, restrictive blood transfusion meaning we are not aim high. Okay, we just aim a hemoglobin to be between 7 to 8 only. Okay, because if you transfuse the blood too much, sometimes you say more than 10 grams per deciliters, you actually increase the pressure in the portal system. Okay, and then you get a rebleeding again. Okay, so 7 to 8 will be sufficient in the GI bleeding. All right. Okay, you talk about telepressing. You talk about octreotide. Okay, so this medication can be used as well to reduce the portal system. And then you talk about intravenous antibiotic. Okay, intravenous antibiotic, you can give a broad spectrum antibiotic like tazocine or ceftriaxone. The reason why you want to give this empirical antibiotic treatment is that because many people coming with upper GI bleeding, they will develop spontaneous bacterial peritonitis at later stage. Okay, so varices bleed is a known cause that triggers spontaneous bacterial peritonitis, and antibiotics should be given for 5 days when they come to the hospital. Okay, and then we talk about endoscopy treatment. Okay, so in the endoscopy treatment, the recommendation for varices need to be done within 12 hours. Okay, for peptic ulcer disease, we talk about 24 hours. For varices, usually it needs to be done within 12 hours. So what we're going to do, okay, you talk about sclerosant injection and so on. We don't do that anymore. Okay, so for esophageal varices, the treatment is the ligation. Okay, the esophageal varices banding. Okay, there will be a treatment. But sometimes what do you find out is that the patient don't have esophageal varices, but the patient may have a fundal gastric varix. Okay, when you talk about gastric varices, there are 4 different types. There is gastroesophageal varices type 1 and type 2, and isolated gastric varices type 1 and type 2. Okay, so for GOV1, the treatment will be the same as esophageal varices, but GOV2 and isolated gastric varices, you can inject a glue inside the varix. Okay, you know that sometimes children with some wound, they don't want to suture, they use acrylic glue in the emergency department. Okay, the blue color, if you have seen that before, okay, that is the same medication we inject in the varix. Okay, what happens is that when the glue injected, it will hardens the blood vessels. Okay, and that will stop the flow of the blood to the varix. Okay, fine. What else you gonna do if this endoscopy treatment fail? Okay, you say about a set second module, isn't it? Okay.
I want to try.
Yeah, sure.
Okay, so just now already mentioned the regarding the ligation and bending. So other than that, we can also consider transjugular intrahepatic photosystemic shunt tips. However, it is only indicated as rescue therapy for esophageal varices bleeding. Otherwise, we can consider surgical therapy, such as esotransaction plus minus devascularization.
Oh, okay, fine. Thank you very much. Okay, so you are right. Okay, so when we talk about esophageal varices that not controlled endoscopy treatments, first we talk about set-second black mold tube. Okay, but I must say that I never used a set-second black mold tube so far. Okay, so it's quite a rare occasion to go to beyond endoscopic treatment nowadays. Okay, but still, the temporary measures to stop the bleeding, you can use a set-second black mold tube. But now with the advancements of the treatment and so on, we have another option as well. We can put the esophageal stenting as well. Okay, fully covered, fully removable esophageal stenting, and these apply the same thing as set-second black mold tube. It's put a pressures on the varix to stop the bleeding. Okay, so this specific stand we call it a Dennis stand. Okay, a Dennis stand. And you talk about tips. Okay, I think that's quite important, because if you look back, what is the cause of the varices is actually a portal hypertension. Okay, it's a portal hypertension, and the tips is actually divert the portal blood to the systemic bloods, hence reduce the portal pressures. Okay, and that can be used as well to treat patient with esophageal varices. Okay, again, this is a quite subspecialized treatments. We don't have it here. In Ireland, I have only seen 2 patients go for tip procedure when we fail endoscopy treatments. Okay, so it's a very specialized, and we actually rarely do, because it's required expertise, and only a few centers are actually doing that.
Doctor, I just want to ask regarding the balloon tamponade, just now that you mentioned. So if I'm not mistaken, the indication for balloon tamponade in esophageal varices bleeding and GOV1 is just if you want to use, if we macam tak silap, the indication is that if we want to transfer the patient to tertiary center. So
yes.
macam it is not.
As I say, it's a temporary measures. Okay, it's temporary measures. It's more like a bridging method. Okay, so you want to send patient for tips. Okay, you won't get the tip within 24 hours. Usually you need to transport the patient, etc., etc. So usually as a temporary measure and bridging patient for a definite treatments, you can put a taken black tubes.
Oh,
Okay,
okay, doctor.
but it's not a definitive treatment. It's only for temporary measures.
Okay.
Okay, all right. Finishing on esophageal varices. If you get a patient with varices bleeding, when we talk about varices, actually we have to talk about primary prevention or secondary prevention. Okay, primary prevention is a patient who have no prior bleeding episode. Okay, patient have liver cirrhosis, you stick the scope and you found the patient have varices, no bleeding. Okay, and this is you want to prevent patient from get the bleeding, and this is what we say primary prevention. But there's also a conditions when you encounter like the case we have now, patient coming with the bleeding. Okay, the bleeding has stopped now, but you want to prevent a future bleeding in the next few months. And this is a secondary prevention. Okay, if you have a patient for primary prevention, you have options of using a non-selective beta blocker like propanolol or carvedilol, or you want to bending varices ligation. And the efficiency for both options are quite similar. So if you look at the Malaysian CPG, actually they are recommended non-selective beta blocker because it's a cheap treatment. You don't need a specialized procedures for that. Okay, but if you're talking about secondary prevention, there is no other way around. You have to do a bending. Okay, but the bending in acute episode need to be followed by multiple sessions after that. So you get acute episode of bleeding, you bend, you let patient go and coming back after 2 to 4 weeks, and you keep bending until the varices gone, totally is gone. Okay. All right. There is no rule of non-selective beta blocker in acute bleeding. Okay, so don't say that, oh, patient come with the upper GI bleeding, you suspect esophageal varices, you want to give a telepressin and beta blocker. Okay, that's wrong. Okay, beta blocker is for prophylaxis or for prevention, not for acute treatments when the patient is actively bleeding. All right. All right. Now, so can you tell me what are the causes of esophageal varices?
The causes are due to portal hypertension.
Arif lagi. Cari orang lain lah pula. Mana orang lain? Tidur ke apa? Ada 100 orang ni. Pukul 3. Dah penat lecture. Okay, I want to talk to you. Okay, I don't want to talk to myself. Takkan besar-besar nak panggil nama lagi.
Doctor.
Yeah.
Causes of esophageal varices is basically due to increase in portal hypertension in patients who have a chronic liver disease or cirrhotic liver disease.
Okay.
That's basically the pathophysiology.
Yes, I agree with you, but esophageal varices is not exclusive for liver cirrhosis alone. So what are the causes?
Portal hypertension.
Yeah, it's caused by portal hypertension, but what are the causes?
Okay, may I try?
Yeah.
So portal hypertension, we can divide the causes into the pre-hepatic, intrahepatic, and also post-hepatic. For the pre-hepatic, which will includes the portal vein thrombosis, and also if the patients have that's all for the pre-hepatic. For the intrahepatic, we have the commonest will be the liver cirrhosis, but can also occur, for example, in congenital hepatic fibrosis, and also in cases of sarcoidosis, invertative disease. And for the post-hepatitis, which includes the Budd-Chiari syndrome.
Okay, fine. Thank you very much. That's very, very good. So the varices is caused by portal hypertension. And portal hypertension is not exclusive caused by liver cirrhosis alone. Okay, I agree with you that many cases that we see all the time is the liver cirrhosis. Okay, because liver cirrhosis is quite common. We have viral hepatitis B, viral hepatitis C in Malaysia. We have a lot of patients with liver cirrhosis. So that's why we see a lot of patients with portal hypertensions due to liver cirrhosis. But as Aklan said earlier on, that portal hypertension can be divided pre-liver, liver, and post-liver causes. Okay, it's quite rare, but you should know about that. Okay, at least 1 or 2 examples for each categories. All right, fine. Okay, I think that's okay for bleeding. I think we move on to the next topic.
Doctor, may I
Yeah.
ask?
Yes, you can.
I want to ask regarding for the primary prophylaxis, we give the patient a beta blocker, non-selective beta blocker. Do we need, how long do we give the patient beta blocker? Is it like for lifelong?
Yeah, lifelong. Okay, lifelong.
Okay, thank you, doctor.
Okay. All right. So let's talk about diarrhea. Okay, let's talk about diarrhea. Okay, we move to a completely different topic now. We're going to talk about a patient with a chronic diarrhea. Okay, so last year I have a patient, 38 years old, a lady, a lecturer in Gambang. She presented with a 3-month history of right iliac fossa pain, diarrhea, and also weight loss of 5-6 kilograms. Okay. Say again. What you say? Are you saying something? No. Okay. All right. Okay. So abdominal pain, chronic diarrhea, and weight loss in 38 years old lady. Okay. So tell me what you're thinking at this stage.
It could be inflammatory bowel disease.
Okay, fine. Anything else?
TB colitis.
Okay, fine. All right, fine. So, okay, first of all, we are talking about quite younger age group of patients, okay, only 38 years old, and come with this chronic diarrhea. Okay, so usually if you encounter a patient with a diarrhea, the first thing that common will be the infections. Okay, but the infection usually won't last more than 4 weeks. Okay, when you talk about commons like salmonella, shigella, etc., this type of infections are not lasted more than 4 weeks unless you talk about patient with immunocompromised, patient have RVD or take immunosuppressors. So this type of patient usually have opportunistic infection like CMV, etc., and that is a different story. Okay, but the rule of the thumb, if you talk about infection, it won't last more than 4 weeks unless the patient are immunocompromised and have these opportunistic infections. Okay, in this part of the world, when the TB is pandemic, intestinal tuberculosis is indeed a very important differential diagnosis. Okay, so we need to rule out the intestinal tuberculosis. Okay, but if you working in Europe or in America, probably that won't be your first differential diagnosis. Okay, because there they don't have much of tuberculosis. Okay, but of course in this part of the world, intestinal tuberculosis should be high in your differential diagnosis. Okay, so you have to take the history about the TB exposure, etc., etc. And of course, in chronic diarrhea like this, we want to rule out the classical inflammatory bowel disease as well, either it's a Crohn's disease or ulcerative colitis. Okay. All right, now, so there are other causes of chronic diarrhea as well. I think that I won't go through that with you. Okay, so let's focus on these 2 or 3 differential diagnoses. Okay, so what you're gonna do? How are you gonna clinch the diagnosis?
Okay, doctor.
Yeah.
So for the first differential is inflammatory bowel disease. So we can ask further symptoms that associated with Crohn or ulcerative colitis, and then we proceed to the second diagnosis, which is TB. So we can ask further question regarding TB contact in the history, and also TB symptom in the past. Okay.
Okay, you can do that, and you still won't clinch the diagnosis. How are you going to clinch the diagnosis now? Okay. Hello? Assalam. Oh, Amira jadi ED hari ni. Okay. 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 Aha. Aha. Sure. Sure. Tak payah, tak apa. Okay, patient ni ada active bleeding tak? Melina hematomesis. Oh, melina lah. Okay, ada anticoagulation ke medication ke? Okay lah, so some medication history lah. So, tak apalah, medical management dulu. Lepas tu, accept lah, kita buat scope. Bagi BPI infusion, lepas tu transfuse pumpai, platelet coagulation apa sama normal. Okay, boleh lah, esok lah. Tapi kalau dia become unstable, nanti telefon balik lah surgeon. Kalau dia stable, esok lah saya buat. Okay, thank you. Alright, so where were we?
How to get the diagnosis?
Okay, how to get the diagnosis. Okay, so I didn't say about history and examination. Okay lah, Amalia Zulkifli.
Yeah, doctor.
Okay, what you gonna do? How you gonna clinch the diagnosis?
Can we do colonoscopy?
Okay, that is right, and that is wrong as well, because at this stage I expect you to familiar how to answer the questions already. Okay, because as we talk about GI bleeding early on, we say we need to talk about the most simplest thing first, the most less invasive thing first, before you talk about more invasive procedures. Okay, the colonoscopy already invasive procedure. What you do before that?
Doctor?
Yeah.
So first we do the blood investigation, such as full blood count, to look for leukocytosis to rule out any infection. And then we can also do inflammatory marker, okay, such as ESR, okay. And then as patient presented with diarrhea, so we can also take the stool for culture and sensitivity.
Okay, fine. Okay. Okay. So first of all, as you say, Adin earlier, that you start with the history and examinations. Okay. So I think that one you already know. Probably we don't need to discuss in details. Okay. You need to ask about TB exposures, the night sweat, weight loss, fever. You talk about actus ulcer or recurrent oral ulcers in IBD. In IBD, we have extra GI manifestation. You have erythema nodosum, erythema pyoderma gangrenosum, uveitis, etc., etc. Okay, so take a detailed history examination focusing on your differential diagnosis. Okay, but let's focus on how you're going to make a diagnosis. Okay, it's actually combinations of many investigations, and please start with the most simplest investigation first. Okay, so that you won't miss. If you talk about colonoscopy straight away, and I'm telling you, you're missing lots of investigation earlier than that. Okay, so the simplest one we can do, we can send a stool sample for culture and sensitivity, for oval and parasite, and also for C. diff toxin. Okay, for C. diff, we need to measure the toxin because the toxin is the cause of the diarrhea. Okay, the toxin A and toxin B. And then we move to a blood test. Okay, the blood test, generally what we're going to look at is the any inflammations or not, either TB or is the IBD. They have high inflammatory markers. Okay, but if patient have IBS, for example, irritable bowel syndrome, and then we expect if inflammatory marker actually would be normal. Okay, so the inflammatory markers are ESR, C-reactive protein, and platelet. Also, usually you can get a thrombocytosis in ongoing inflammations. Okay, and then you want to use this blood test or investigation as well to look at the severity of the problem. Okay, when you talk about colitis, you need to know what are the severity of colitis, and usually patients with a severe colitis, they usually have anemia because they're not just a normal diarrhea, you get a bloody diarrhea, and sometimes the bleeding won't be able to see, you can have occur bleeding. Okay, you need to see the albumin level as well. Okay, that's a very, very important, because we know if you have inflamed bowel, you can have a lot of leakage of the protein in the intestine. Okay, we call that a protein loose gastropathy. Okay, this is a protein leakage due to severe inflammations in the bowel. Okay, so if you have a patient with albumin of 20 or so, I'd be worried. Okay, because I know this patient has severe inflammations in the bowel. Okay, and then you talk about investigations of tuberculosis. Okay, it's the same as pulmonary tuberculosis. You still need to do the chest x-rays to make sure there is no pulmonary tuberculosis. You can do a MOT test. You can do a quantiferin as well to check for the latent tuberculosis, and you can have a radiological investigation as well. Okay, so radiological investigations is quite important in IBD, because in IBD we know in Crohn's in particular, it's not just affecting your large bowel, it's also affecting your small intestine as well. Okay, you can do OGD to look from the mouth into the D2, okay, to the duodenum, and you can do a colonoscopy to look from the inner canal into the terminal ileum. But between the duodenum and terminal ileum, you have a 6 meter of small bowel. Okay, and this 6 meter of small bowel are not accessible to our standard endoscopy. Okay, some center they have a double barrel endoscopy, capsule endoscopy, etc. to look for a small bowel pathologies. Okay, but the standard endoscopy, you just look for the 1 meter out and 1 meter below. Okay, the radiological investigation.
Because I want to meet a dean of the fourth class.
Alright, okay, sorry about that. So the radiological investigation also can shows few more things. For example, in IBD, we're talking about extra GI complication early on, but they also have intra GI complication like bowel perforations, abdominal abscess, fistula, and so on. Okay, so the radiology can look at these complications. Okay, yeah, the ideal thing is the MRI, but if not, CT abdomen would be okay as well. All right, and finally, you talk about endoscopy. You want to look at the features of endoscopy. Sometimes, you know, in Severity of Colitis, you can see a pseudomembranous colitis, which is you can get this kind of patch on the mucosa of the colon, and usually classical for Severity of Colitis. Okay, you look for skip lesion in Crohn's disease, you look for the Eptus ulcer, you look for longitudinal and horizontal ulcers, you look for cobblestone appearance, you look for pseudopoly. So there are many features in endoscopy. Actually, you can determine whether this is UC or Crohn's disease or infection colitis, etc., etc. Okay, and not to forget, the endoscopy is just look at the appearance of the colon, but you have to take biopsy as well. Okay, and that is most of the time when you can get the diagnosis. Okay, you need to take the biopsies, and you need to look at the microscope and to see features of IBD, features of infections colitis, features of intestinal tuberculosis. Okay, all right. So this patient actually was treated in KMC by Dr. Hazri, and he did the inflammation markers all up. The patient have low albumin, have anemia, and he did the colonoscopy. It shows that there's a lot of inflammations from the hepatic flexure up to the cecum with formation of polypoidal mass. Okay, he sent the biopsy for NTB culture, which was normal, for TB PCR, which was normal, but the quantiferon come back positive. Okay, and the histology showed that is a granulomatous inflammations. Okay, so what will be your thinking at this stage? With the information given?
Intestinal TB.
Okay, you like to think about intestinal tuberculosis. Okay, I do agree with you, and Dr. Hazri also agreed with you. He actually started this patient with Accurate 4 and referred to me for further management. Okay, so when I saw this patient, I say, okay, this patient have quantiferon positive, and the patient have granulomatous inflammation on histology. Okay, so there are two differential diagnoses we're going to talk about here. When we talk about granulomatous inflammation in the bowel, we have to talk about Crohn's disease, and we need to talk about intestinal tuberculosis. Okay, and the problem is that despite correlation between clinical, biochemical, radiological, endoscopy, and histology, sometimes it's impossible for you to determine if this is intestinal tuberculosis or this is a Crohn's disease. Okay, so you have to know, I think before this preclinical, you're talking about ulcerative colitis versus Crohn's disease, and you need to differentiate between these two things, okay? But now you also need to differentiate between Crohn's disease and tuberculosis, okay? So usually people with tuberculosis, they have no skin lesions, okay? Usually they have segmental inflammations, but they have no skin lesion. Kejap take 5.
On scope.
Okay, all right. Okay, so I think this topic you can look out, okay? How do you differentiate between tuberculosis and a Crohn's disease, okay? But I just say briefly to you that there are a lot of debate, a lot of discussion, and there are no one features to suggest one or another, okay? There are rules, but all the rules can be broken. And the difficulties persist. How do you say this is a TB or this is a Crohn's disease? Okay, so I think that we don't need to go through that, but if you're interested, you can look further in the literatures about that. Okay, so anyway, when you talk about granulomatous inflammation, you have to talk about TB and you need to talk about a Crohn's disease, okay? But the difference between Crohn's disease and TB, if you go back to your pathologist days, they will say that in TB, usually is a well-formed, matured, and usually it's a big granuloma, it's a macrogranuloma, it's a big granuloma, and there are lots of granulomas, okay? But whilst in Crohn's disease, it's usually poorly formed, it's a microgranuloma, it's a small size of granuloma, and it's scattered, okay? Maybe in one slide, you see 1 or 2 granuloma only. In TB, you can see everywhere, okay? So that would be the case. All right, and then the next thing is that this patient actually was treated for intestinal tuberculosis. Number one is because of the fact that in Malaysia we have this pandemic of tuberculosis, and number two because of the granuloma. Unfortunately, the histopathologist cannot make out is that a granuloma from TB or a Crohn's disease. Okay, it's a very difficult thing to do. But what I like to talk is about the quantiference. Okay, what do you think about the positive quantiference?
Latent TB? Can it be latent TB?
Yeah, I agree with you, The quantiferon is the same as a MON2 test, okay? And usually it's indicate latent tuberculosis. But now the patient has the symptoms, okay? So is this active TB or is this a latent TB?
Probably the reactivation of latent TB, Doctor?
Yeah, you mean that's active TB lah kan? Okay, so how do you diagnose active tuberculosis? Okay, so that's important as well, because as far as we know, by quantiferon does mean that the patient probably have a latent TB, but it's not proof that the patient have a active tuberculosis. So usually if you want to know for sure, you have to send the MTB culture and sensitivity. It takes about 8 weeks or so before you get back, but the MTB culture can be usually positive. You can send the gene expert as well, or the PCR, okay, tuberculosis PCR. Okay, and of course the histology that I told you early on, but sometimes the histopathologists have difficulty in interpreting the slide to diagnose the intestinal tuberculosis, okay? So that's exactly what happened to us, that MTB culture was negative, PCR was negative, quantiferon was positive, but the histology, we are not sure, okay? So we comment with the intestinal tuberculosis treatment for 8 weeks, and then we rescope again after 8 weeks. And then we scope again, we found out that the inflammation is still there. There's not much improvement at all. At this stage, we have do a revision of diagnosis because the patient have no response to anti-TB medication after 8 weeks. Now we are treating patient for a Crohn's disease with latent tuberculosis, okay? So, do you want to tell me how do you treat Crohn's disease?
Treat by giving immunosuppression such as methotrexate.
Anybody else want to try?
Doctor, may I try?
Yeah.
For the first line for Crohn's disease would be the mesalamine 5-ASA, for example, the sulfasalazine and also the osalazine. So this functions by inhibiting the interleukin and also the tumor necrosis factor. Then we can also consider giving glucocorticoids for suppressions of the inflammations. And we can also opt for anti-TNF, which includes the infliximab.
Okay, fine. Okay, so this is a very, very interesting area to talk about, because in the past few years, we have lots and lots and lots of research concentrated on these areas, and we get more and more and more better medications. Okay, so in old days, you probably saw it during your preclinical times that IBD, we have kind of pyramid structures with the options of the treatments, okay? So that one is a classic, okay? That is a step out management for IBD. But later on, people talk about top-down approach, which is give the best medication for a Crohn's disease, and then you reduce the medication as necessaries, okay? But now we are moving towards another approach we call the treat to target approach, okay? What is the treat to target approach? Treat to target approach is the same as your hypertension, is same as your diabetics, okay? You have a target, okay? In diabetes, your target is HbA1c. In your blood pressures, you want a systolic less than 140 over 90, etc., etc., okay? So, why do we change this approach? Okay, the reason we change the approach is because we know now that IBD is a progressive disease. meaning the longer you get the inflammations, the higher chance for you to get the complication. Okay, you can start with the chronic inflammation, and then you get a scarring of fibrosis. When you get a fibrosis, you get complication of strictures, fistula, bowel perforations, and then when you get a longer time, it will develop into cancers. Okay, so what you want to do is that you want to treat early a stage of inflammation to prevent fibrosis, because once you get a scar, there's no medication can reverse it. Okay, the patient will end up with a surgery. Okay, so we are talking about change cause of the disease from the progressive disease, and we want to change it, this cause of the disease. Okay, so when you talk about treat to target, you need to know what is the target in the treatment of inflammatory bowel disease. Okay, the treatments, the most linear one that we used before is the clinical remission. Okay, that means that the patient say, oh, sakit perut tak ada dah, diarrhea tak ada dah, dah boleh makan. Itu clinical remission lah. You look at the symptoms and signs alone. Okay, but now we know that the patient, or more than 50% of patients with the clinical remission, they actually have active disease. Okay, they don't feel pain, they don't have diarrhea, they can tolerate orally, but they still have active disease, they still have inflammation in the bowel, and if you don't treat this inflammation, they will have a fibrosis sooner or later. Okay, so now we're talking about mucosa healing. Okay, so you treat the patient and you scope the patient again. You want to make sure that the patient have no more inflammation in the bowel, and that would be your target. Okay, but we are not happy with that as well, and now we want to go one step further. Okay, to what we call that deep remission. Okay, deep remission is not just you see that the mucosa is okay, but you want to take the biopsy and to look under microscope. You want the histological resolution of inflammation as well. Okay, either your target is mucosa healing or deep remission. Is still debatable, is still under studies, etc., etc. But this is the target that we want to achieve. Okay, at very least mucosa healing and maybe deep remission in the near futures. Okay, so the aim of the treatment is very, very important, because if you don't have the aim of the treatment, it's very difficult to treat. Okay, you don't know when to start this medication, etc., etc. Okay, now we need to look at the options of the treatments. Okay, when you look at the treatments, usually they will say you there is induction of the treatments and the maintenance of the remission. Okay, induction of remission and maintenance of remissions. Okay, and the common drug we use for induction would be a corticosteroid. The corticosteroid you can have a topical corticosteroid by giving enema. Okay, you can give through enema, or you can have a oral topical corticosteroid like budesonide. Budesonide is not absorbable by your gut, so you eat it, it stays in the gut. Okay, and then you can have systemic corticosteroid like oral prednisolone or intravenous hydrocortisone or intravenous methylprednisolone. Okay, so this is your steroid option, and usually we use a steroid for inductions of remission. Okay, Aklan said about mesalazine early on, but what we found in the studies is that mesalazine actually is not work in Crohn's disease. It do work in ulcerative colitis though. So in the latest guidelines, we are not recommend to use a mesalazine to treat a Crohn's disease anymore. Okay, there is no additional beneficial of using a 5-ASA in a Crohn's disease, but we still use it in the ulcerative colitis. Okay, And then we talk about immunomodulators. Okay, when we talk about immunomodulator, we talk about azathioprine, we talk about metacaptopurine, we talk about methotrexate. Okay, this medication are still used. It's been in the market for 50, 60 years now. So we are quite comfortable to use this medication. We know the side effect profile, etc., etc. Okay. But the problem with this medication like azathioprine is very, very slow onset medication. It takes about 2 months before patient can get any benefit from the azathioprines, and take about 6 months before they get optimal effect taking azathioprine. So if you have a patient that need urgent treatment, azathioprine won't be recommended, okay, because it takes a long, long time to work. Okay, the side effect of azathioprine like acute pancreatitis, hepatitis, it can cause a small risk of lymphoma as well. Okay, and then you talk about biologic. Okay, so this biologic agent in 10 years ago, maybe we talk about one single class, okay, anti-TNF alpha like infliximab, and then we have adalimumab, the same as infliximab, anti-TNF alpha. But in the past, we get more and more. Now we have anti-integrin, vedolizumab, and last year we got anti-interleukin, ustekinumab, and then on the study now we have any JAK kinase inhibitor as well, and we have few more on the pipelines. Okay, so this era of biologic is moving very, very fast. We get more and more medication, and these medication are getting better and better. Okay, so I don't think you need to know in details, but you need to have some idea what the options of the treatments and what are the target of the treatments. Okay, I'm not expecting you to know in details about infliximab or vedolizumab or ustekinumab or something like that. Okay, but I want you to know how to treat that. Okay, what you want to do, what is your aim of the treatments, and what are the options available. Okay, so this patient actually we start on steroid treatments and azathioprine, and the patient actually improved very, very well. She gained from 32 kilo when we first treat her. Now I saw her last week, she have 52, 53 kilogram back to her baseline. She have no more abdominal pain. She have no more diarrhea. She quite energetic. She can start working again. Okay, but despite her clinical remission, when I scope her again last month, I can see still a lot of inflammation, a lot of stenosis, and I'm not happy with her current treatments. Okay, so I will send her to Hospital Tengku Alpuan Afzan to start her on vedolizumab. Okay, we need to step up the medication until we reach the target. Okay, at very least is the mucosa healing. All right, fine. Okay, that's quite detailed. I think this case here are quite detailed. I don't need you to know all about this at the moment. Okay, but if you're interested, you can know about it. Okay, for IBD, I just go quickly. Okay, what you need to know about IBD as an undergrad. Number one, you need to know how to make a diagnosis of IBD using clinical, biochemical, radiological, endoscopy, and histology. Okay, you need to know that what are the extent of the disease. Okay, you know that in ulcerative colitis, you can have distal disease. In proctitis alone, you can have left-sided disease. You can have extended left-sided disease. You can have pancolitis. Okay, not all patients we usually have pancolitis. Sometimes they only have the distal disease. Okay, so you need to know extent of the disease. In Crohn's disease, you can have the disease everywhere. Okay, of course, the commonest is terminal ileum, but you can have the inflammation in the stomach, in anywhere in the GI tract. Okay. Number 3, you need to know the severity of the disease. Okay. Of course, we talk about rulers, criteria, and so on, but mainly you talk about the symptom. How many bowel motion are they have every day? You talk about toxic. Okay, toxic is a systemic manifestation, especially tachycardic or having fever. And then you talk about biochemical anemia, hypoalbuminemia, and increased inflammatory markers. Okay, and number 4, you have to talk about medication. Just now I talked to you about the option of medication, but you also need to know the side effect profile of medication. You may be asked, what are the complications, what are the side effects of azathioprine, etc., etc. Okay, number 5, you need to know about extra GI manifestation of IBD. Very, very common question you'll be asked in the exam. Okay, you need to know, uveitis, arthritis, large joint arthritis, ankylosing spondylitis, large joint arthritis, erythema nodosum, pyoderma gangrenosum, PSC, etc., etc. Okay, so they will be asked in the exam. You need to know about intra-GI complication of IBD. I talked about that earlier on, bowel perforation, strictures, fistula, abscess, and so on. And cancer as well, okay, it turns into cancer. And then lastly, it's about nutritional status, okay? So patients with IBD, usually they have a low nutritional status, especially people with a small bowel disease, okay? So there, probably you don't need to know in details, but the best measurements of nutritional status would be the BMI, I think, okay? Because the patient with low albumin may just indicate the severity of the disease. All right, any question you want to ask me about IBD?
Doctor, with regard to the patient, for the choice of treatment, because the patient had latent TB with positive quantiferon, still we consider biological agents.
Okay, very, very good questions. First of all, this patient, we have complete the treatment for latent TB. Okay, we have complete a 4-month treatment for the latent TB. So we're hoping the risk of reactivation is low. And secondly, now we have options of treatments. Okay, I told you we have anti-TNF-alpha, we have anti-integrin, anti-interleukin, and now we look for JAK kinase inhibitor as well. The anti-TNF-alpha is a systemic medication. It's not used to treat IBD before. When it first come out in the market, it's used to treat rheumatoid arthritis. Okay, but now we found out it's also working in IBD. But the thing that I want to stress is a systemic medication, okay, affecting all over the body. But now we have anti-integrin. Vedolizumab is a gut specific, okay? It's not gonna affect other organ, it's a gut specific. And in the studies, we found out that rate of TB reactivation with vedolizumab is very, very low. And that's why I told you this patient, we actually gonna refer to HCA for vedolizumab, okay, not infliximab, okay? The ustekinumab with the anti-interleukin also have a good side effect profile, but not as good as vedolizumab, okay? So vedolizumab will be a number 1 safer for this patient, followed by what we call that, ustekinumab, okay? But in all days, when we don't have this option, we do give a patient infliximab as well, okay? But we have to treat the TB first, okay? That's why when you look at our approach, when we don't know, is this a Crohn's disease or this is a TB, we treat the TB first for 8 weeks at least. And then we start biologic agent, steroid, and so on. Because if you give the immunomodulators, anything that reduces the immune system earlier, it may backfire you, okay? It can make the TB uncontrollable. Okay, patient could die from that. Okay, any other question you want to ask about IBD? Yeah.
Okay, I would like to confirm that regarding you mentioned about the pharmacological treatments for the IBD. So we have the reduction for remission, also retain remission. So for the reduction of remission, is it only the corticosteroid, and for the immunomodulators and biological agent, is it for retain remission?
Okay, fine. Okay, that is a very good question. Okay, so first you want to know, when you select the medication for IBD, you want to know 3 or 5 things. Okay, the first thing, how efficient is the medication in terms of how fast it's working and how good is the medication. Number 2, you want to know what are the side effect profile of the medication. Number 3, you want to know what is this medication is available, or is it any problem with the cost, or it's not available in Malaysia, or is it under studies. Okay, and lastly, you want to know, can patient be compliant with this medication? Okay, because some of the medication, patient need to come to the hospital because it's given intravenously. Some medication the patient can take at home, like insulin pen, okay, subcutaneous injection, but the JAK2 kinase, JAK kinase inhibitor is oral tablet, okay, maybe better for compliance. So there are few things that you look out when you talk about the selection of the medication. Okay, and we're just going to talk about the first one, the efficiency of medication. Okay, infliximab is working within days. Okay, 1 day, 2 days, 3 days, 4 days, we expect infliximab to work. Okay, but other biologic agent, vedolizumab, ustekinumab, adalimumab, work very slow. We're talking about weeks or months. Okay, we talk about weeks or months. So if you look at the algorithm for IBD, in acute severe colitis, they recommend corticosteroid. If corticosteroid fail after 3 to 5 days, you should consider infliximab. Okay, the only biologic agent that we use in the acute setting. Okay, but also we have option of use a cyclosporine as well. Okay, a cyclosporine. Okay, so Professor Idahimi from have developed algorithm for treatment of IBD. If you're interested, you can look at the algorithm as well. Okay. All right. Any other question?
Dr. Nik, I just want to ask regarding the case. Actually, for the like the intestinal, if we suspect intestinal TB, we need to take the culture and severity. So for intestinal TB, we take it from the stool, the sample.
No. Ideally, you can take from the just send the stool for MTB culture, etc., etc. But it's not acceptable by the lab. So what we do is that we do the endoscopy, we do terminal ileal intubation, and we take a biopsy from a terminal ileum. Okay, a tissue biopsy from terminal ileum, same for MTB culture, MTB PCR, or gene expert. Okay, that is the site that commonly affected. Okay, for intestinal tuberculosis, ileocecal area regions is the commonest site of intestinal tuberculosis.
Okay, and then for the Crohn's disease, because it can the site of the inflammation can go anywhere, also at the upper gastrointestinal. So we need to do the endoscope yang upper GI juga, doktor.
Yes, exactly. Okay, so this patient also have OGD and a colonoscopy. That is not a problem. Okay, you can score 1 meter up, 1 meter down, no problem at all. The problem is that 8 meter in between the duodenum and terminal ileum. Okay, so what we do now is we use cross-section imaging, a CT scan or MRI small bowel to assess if patient has small bowel disease. But there are options in the centers. They have a double balloon endoscopy. This is a very specialized endoscopy. They can go into small bowel as well, but take a lot of times and effort to do that. Okay, hours to go or see the whole small bowel. But we also have options of doing a capsule endoscopy. So basically you're going to swallow a camera and then we're just going to process the image to see is there any inflammation in the small bowel or not. But the problem with this is that you can see the endoscopy imaging, but there's no way for you to take a biopsy for histological diagnosis. Okay, so small bowel, we are actually improving. We have more developments in terms of the investigation of small bowel disease, but it's still uncharted territories for us. Okay, it's still a gray area and difficult to investigate and deal with. Okay.
So even though there are no symptoms of upper GI, also we just we need to do.
Yeah, actually I will check for Crohn's disease. I will screening all everywhere, okay? Because I told you earlier on, the study shows that people with the clinical remission, more than 50% of them still have active inflammation in the bowel, okay? So clinical remission, or you still have no symptom, if a very weak measurements to say you have active disease or not.
So the most easier one is just CT lah doktor untuk semua kali.
Yeah, upper and lower scope and cross section imaging.
Alright, thank you doktor.
Alright, any questions?
Doctor, I want to ask regarding yang certain patient saya nampak the diagnosis is indeterminate colitis. So how do you approach this and treat them if you do not know them one or?
Oh, okay. There is no such thing as indeterminate colitis. Okay, the indeterminate colitis is a failure of the physicians and histopathologists to make a diagnosis. Okay, the patient will have a Crohn's disease, ulcerative colitis, intestinal tuberculosis, but regardless, all what we do, you know, the clinical, biochemical, endoscopy, radiology, histology, there will be some gray area we cannot determine. Is this Crohn's? Is this UC? It is intestinal colitis, and that's why you get this undetermined colitis and so on. Okay, but this entity is basically you don't know. Okay, you don't know. But end of the day, later on, when we get a more clear pictures, we know this is a Crohn's disease or intestinal tuberculosis. It's the same as this patient that we discussed earlier on. When he initially presented to KMC, he got the histology of granulomatous inflammation. We don't know. Is it Crohn's? Is it intestinal tuberculosis? Okay, so this is undetermined colitis. If you look at the histology report, it says undetermined colitis because they don't know. Okay, but we treat the patient. The treatment is not working. That means the diagnosis is wrong. Okay, so that's why we move from the TB diagnosis into the Crohn's diagnosis. And then we treat the Crohn's and the patient responds very, very well with this corticosteroid. That means we get the right diagnosis, okay? Now we are sure this is a Crohn's disease, okay? Sometimes in the clinical setting, it's not like in the textbook where you always get the answers, okay? If you look at the medicine, your exam questions, there will be always an answer. 100% you can get the diagnosis, okay? But in the clinical setting, many times we treat the patient, we didn't get a proper diagnosis, okay? We have to treat the patient empirically and see if the patient responds to the treatments or not. Okay?
Doctor, may I ask, regarding inflammatory bowel disease, what is the role of surgery in such cases, doctor?
Okay, the role of gastroenterologists is to prevent surgery. Okay, but saying that, for Crohn's disease, we still have a lot of people going for surgeries. Okay, we still have a lot of people going for surgeries because of complications. Okay, usually the surgeon coming in when we fail the pharmacological treatments. Okay, we talk about bowel perforation early on. We talk about intra-abdominal abscess early on. We talk about strictures. The strictures, you can have inflammatory strictures, you can have fibrotic strictures. If patient have bowel obstruction due to fibrotic strictures, no medication can help the patient. They need a surgeries. Perianal disease, fistula, there are surgical rules, okay? But we're hoping with that, with more and more drug coming to market, we can prevent patient from getting the surgery. Okay. Now, there is a paper published as well recently by Asian Pacific Group interested in IBD about role of surgery in IBD. Okay, if you're interested, you can look at that literature as well. All right, any other questions about IBD?
I have question. Maybe I missed this part about the diagnosing IBD for Crohn's disease. To differentiate Crohn's with tuberculosis, intestinal tuberculosis. From what I know, the histopathology show caseous granulomatous histopathology, so it's more likely TB. However, from what there's some cases the IBD or the Crohn's disease also show caseous granulomatous, but from what I read also from the book, it say Crohn's disease will show non-caseous granulomatous. How do you comment about this? Thank you.
Okay, I told you early on, when you talk about intestinal tuberculosis versus Crohn's disease, every rule can be broken. Okay, every rule can be broken, and that's why it's a very, very difficult and dilemma for us to make a diagnosis. Okay, but as far as you need to know, the features that suggestive of Crohn's disease are non-caseating granuloma, is microgranuloma, is small in size, and is scattered granuloma. Okay, it's associated with architecture distortion. Okay, that's mean you can get creep distortion, creep angulations, creep enlargement, etc., etc. Why in the intestinal tuberculosis is a form caseating granuloma, is bigger, is more frequent seen in the slide. Okay, but there are also radiological features that suggest of Crohn versus intestinal tuberculosis. Okay, there is also clinical features to suggest one or another. Every rule can be broken. Okay, what you can say, this feature is more suggestive of Crohn's, this feature is more suggestive of intestinal tuberculosis. All right.
Thank you.
Okay, any other questions?
Doctor?
Yeah.
In terms of nutrition and diet, is there any difference between patients with IBD and normal person?
Okay, in Australia, they have done a lot of studies about diet in IBD, and as far as I know, there is no specific diet as at the moment for IBD. Okay, this is about the diet. Okay, because we talk about low FODMAP diet in IBS, we talk about elemental diet in pediatric Crohn's disease, etc., etc. Okay, but for elder Crohn's, there is no specific diet, but you need to address the malnutrition. So, okay, if patient like my patient coming with a low BMI weight of 32 kilogram, you need to address the nutritional requirements. Okay, but similar to other people, no specific diet for IBD. Okay, any more questions? No more questions? No more question. Okay, very good. So now you know all about IBD. Okay, so we move to another case now. Okay, we're gonna go to completely a different topic now. We're gonna talk about a liver. Okay, we're gonna talk about the liver. Okay, I have a patient that come to me. Okay, this patient is a pregnant lady, and as part of the pregnant assessment nowadays, in the past 1 or 2 years, they have now checked for viral hepatitis B infections. Okay, so she come to me for further management. Okay, so I want to ask you about the screening viral hepatitis B. How do you screen for viral hepatitis B?
For hepatitis B, doctor?
Yes.
So for hepatitis B, what we can send is the surface antigen. So this indicate the active infection, and then we can also HBC. The core one is the pus infection, and then another one is I didn't remember. Sorry.
Okay, fine. Okay, you are partially right there. Okay, hepatitis B and hepatitis C are very, very common. Okay, are very common. Okay, if you go to HCA, you see on daily basis. Okay, so you need to know about viral hepatitis B and C, at very least how to diagnose these conditions. Okay, so we're talking about a screening test. Okay, when you talk about screening test, you need to send 3 investigation. The first one is the S antigens. Okay, when you talk about antigen, this is the proteins that attach to the virus, kan, antigen, kan, sama dengan NS1 antigen in dengue, kan. So antigen mean the virus itself. Okay, if you have positive surface antigen, that means you have the hepatitis B. Okay, and then you need to send for anti-core antibodies. This is antibodies. Okay, it's not the antigen. It's not represent the virus. It's represent that the body now has respond by producing antibody against this virus. Okay, so when the body gonna produce this? When there is an infection, but either the infection is still there or the infection already gone, we don't know. Okay, we don't know. The only thing that we know is that the body has exposed the virus at some stage, but either the patients they have the virus or not, we don't know. Okay, and the third one is the anti-surface antibodies. Okay, this again is antibodies, but these antibodies is only will be positive or reactive or high in patient who have resolved infection. Okay, that means when you have surface antibodies, meaning you won't have surface antigen, because surface antibody will attack the surface antigen. Okay, it combines the surface antigen. So by right, if you have seroconversion of surface antigen into surface antibodies, this means that you are cured from the viral hepatitis B. Okay, but there's also a condition when you get surface antibodies high, which is the vaccinations. Okay, but how do you know this is vaccinations or this is a resolved infection? You need to look at the core antibodies. Okay, that's why the core antibodies is important. It will differentiate if a patient have immunization toward viral hepatitis B or if the patient actually has the resolved infection. Okay. All right, so you need to know that at very least you need to know how to do a screening for chronic virus hepatitis B. Okay, so turn out this patient have surface antigen positive, surface antibody negative, and core antigen positive. So what does it mean?
Current active infection of hepatitis B.
Oh yeah, is it acute or chronic?
It's acute currently, so surface antigen is positive.
No, surface antigen will be positive in chronic as well. Okay, so what determines acute or chronic is the infection lasted more than 6 months. Okay, chronic must be more than 6 months. Okay, sometimes you can get result infections. Okay, but this lady probably got it a long way before that. Okay, most likely a chronic. Okay, but if you want to see for sure, you need a 6-month period.
Doctor, yang 6 months period, so we have to ascertain by symptoms. So kalau patient tak ada symptoms, how do we know dah 6 months or not?
The serology persistent for 6 months.
Sorry, come again?
The serology, the antigen, surface antigen is positive for more than 6 months.
Alright, thank you.
Okay, so I asked her, how do you get the virus? Okay, so you want to tell me how this chronic viral hepatitis B transmitted?
So for hepatitis B virus, it actually can be transmitted due to blood transfusion and then sexual contact.
Okay, anyone else want to add on that?
Another one is the vertical transmission.
Yeah, okay. So that is the difference between us and the European countries, okay? Because we have a pandemic of chronic viral hepatitis B. We have lots and lots and lots of vertical transmissions, okay? Whilst in the Western countries, they don't have this vertical transmission. They only have the acquire, okay, the acquire one, okay, as you say, transfusion, sexual contact, and so on. But it play a major roles in what we're gonna do with our patients, okay, because the vertical transmission and acquired transmission actually behave like two different disease. Actually, they are not the same, okay? Did you know what are the difference between these two?
The vertical transmission is more severe than the horizontal transmission.
Why?
Because one is responsive to drugs and one more is not very.
Not really, okay, not really. But what we found out is that patients with the vertical transmission, they have 90% chance to go to a chronic stage. Okay, why? Patient with acquired chronic viral hepatitis B, they have 90% chance to be cured. Okay, that means that only 10% we go to a chronic stage. Okay, so that's why in the Western population, they don't have vertical transmission. The prevalence of chronic viral hepatitis B are low. Even if they acquire, it goes away in 90% of the patients. But in our clinical health setting, the chronic viral hepatitis B transmit from mother to child, and when they get it, there's 90% chance that they will continue to have it, and then when they have the child, their child also have the risk, and the cycle continues. Okay, that's why it's very important for us to break the cycles. Okay, we need to break the vertical transmission cycle, and that's what we do now. we will screening all mother for chronic viral hepatitis B and try to reduce risk of vertical transmissions. Okay. When you talk about chronic viral hepatitis B, you have to know the phases in the chronic viral hepatitis B. Okay, interesting reading for you if you are interested. In chronic viral hepatitis B, the first phase we call that immunotolerance. Okay, immunotolerance meaning that the virus is in the body, but the virus not causing any problem to you, so your immune response are not activated. Okay, maybe there is some immune response, but not much. Okay, that's what we call immunotolerance. Okay, the immune response still can tolerate with this and not really react to this. Okay, and this only happen in vertical transmission. Okay, when you get the disease when you are born, but not happening in acquired disease. Okay, because in LDAC you already have a mature immune response. You get something new, your body will respond straight away. Okay, but in the child, the immune response are not well developed yet. They still say, oh, this is okay because they got when they are born. Okay. And then you get, so this stage will prolong for 10, 20 years in vertical transmission. And then the patient will go to a second stage, we call that immunoreactive. Okay, at this time, the body already say, oh, this is not right. This virus not belong to the body. We need to get rid of this virus, okay? So this is where you can get a lot of immune response, and what you get is the E antibodies, okay? Hepatitis E antibodies, okay? Anti-hepatitis E antibodies, okay? And this anti-hepatitis E antibody will attack the hepatitis E antigens, and there will be a seroconversion. That means that there's no more antigen, there's only antibodies, okay? It's not as antigen, okay? This is a C core. E antigens. Okay, this E antigen is a replicative phase lah. Maksudnya kalau virus not replicate, usually they have they're using this E antigens. Okay, and then when this happen, when the immune system control the virus, you can have what we call that low replicative phase. Okay, low replicative phase because there is no more E antigen. Okay, E antigen are responsible for replication phase. Okay, so at this stage, the virus is there, but at low level, at the low level. Again, most of the patient with chronic viral hepatitis B in the clinic. Okay, and the final stage is reactivation of chronic hepatitis B. At this stage, the immune response are not longer able to control, and the patient start coming with the jaundice and decompensated. Okay, there are 4 stages of chronic viral hepatitis B. Okay, if you are interested, you can read about that. Okay, so this patient that come to me, okay, sekejap Hello. Assalamualaikum. Berapa tahun? Oh, 84 dah. Okay. 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 Tak apa, minta sejen tengoklah. Tak apalah. Tak, dia memang absolute, maksudnya memang bawah dilator, dia ada absolute constipation dan sebagainya. Memang bawa obstruction lah patient ni. Dia kalau IO bukan kita tak ambil lah. IO kita tak ambil. Kita nak suruh tengok dekat periphery tak apa. Tapi IO lah. Okay. Okay, sorry about that. Okay, so where were we?
Reactivation phase.
Okay, reactivation. Okay. Reactivation, kita dah habis reactivation.
Dah bila?
Okay. So where are we now? Tanya.
Phase.
Okay. I still also cannot remember. Okay. Fine. Okay. So hundreds of you are sleeping as well behind the computer. Tak ingat juga. Fine. Okay. So so this patient have this patient actually have a surface antigen positive, core positive, and anti-core and surface antibody negative. Okay, so it has active, it has a chronic viral hepatitis B infection, but her ALT is normal. So that means that the virus is not actually attacking the liver. Supposedly, theoretically, you need to do a viral load, you need to do E antigen, E antibody, and so on. But for me, this patient probably stay in the immunotolerant phase. Okay. So in terms of the treatment for chronic viral hepatitis B, usually you don't start the treatments unless there is active inflammations going on. That means that the ALT should be more than two upper limit of normal, or if patient already starting to develop fibrosis and a cirrhosis from chronic viral hepatitis B. Okay, so there's no indication for treatment for this patient yet, and the treatment that can be offered is antiviral like tenofovir or entecavir. Okay, this is pan-genotyping penetrating antiviral medication. Okay, all right, but I told you this patient is pregnant. Okay, so we are not just going to treat the chronic viral hepatitis B for this patient. If just for this patient, there is no indication to start treatment. Okay, but we also want to talk about the baby. Okay, can we reduce the risk of the baby to get chronic viral hepatitis B infection? Okay, once the mother have surface antigen positive, straight away the baby need to get the immunoglobulin, active and passive immunization within 12 hours of delivery. Okay, straight away if they have a surface antigen positive. But there is also a role of antiviral treatments if a patient have viral load more than 200,000. Okay, so that's exactly what we do for this patient. We send the viral loads, and the viral load come back 2 million and so on. Okay, so we start this patient on tenofovir at week 28, and we're hoping that we will reduce the risk of transmission to the baby. Okay, fine. All right, any question about this? Okay, I think you want to talk about one topic, it's going to be the whole day. Okay, so that's why I think this is a revision. That means that you already read about the topic. We're just going to tidy out the loose end, what you don't understand and so on. Okay, no question?
Doctor, regarding choice of medication just now, you said about antiviral, entecavir, and tenofovir. Kalau interferon alpha, we don't use it.
Okay, PEG interferon, we rarely use it. Okay, the advantages of use PEG interferon is that it's only short term, 6 to 12 months only. But after that, no need to use if the treatment respond. But if you use nucleoside antiviral, the problem is going to be a lifelong. Okay, it's going to be a lifelong. So some people say don't want lifelong medication, take PEG interferon. But the PEG interferon also not really effective, probably 60 to 70% chance they can be effective. So there are 30 chance that they still need the tenofovir or entecavir.
All right,
Okay.
thank you.
Okay, any other question? Okay, we need to speed out now, okay? So chronic viral hepatitis C infection, very, very interesting. The reason why it's interesting is that because in Malaysia, we have now have the drug available, okay? The all-oral DAA is a very, very effective medication to treat all viral hepatitis C infection. The curative rate is more than 95%. And now the KKM managed to get a deal with the drug company to get it at the cheapest, and now it's actually freely available in the government hospitals. Okay, now with this new availability of the drug, we're aiming to eradicate the chronic viral hepatitis C in Malaysia in the next few years. Okay, it's difficult things to do because we don't have vaccine, but as you know, that the group that high risk to get chronic viral hepatitis C usually are IV drug users and so on. Okay, so we still can treat them even though we don't have vaccine and so on. So I encourage you to look at this all-oral DAA because that is something news for Malaysia healthcare that we haven't seen last year. Okay, I don't want to go too much about hepatitis C unless you have any more questions.
Assalamualaikum, Doctor. Regarding the immunization, does the immunization like really helps the patient and it's reduce the chance for vertical transmission? It's for to educate, basically to educate the patient.
Are you talking about hepatitis B?
Yes, for hepatitis B.
Hepatitis B, okay, all right, okay, because we don't have vaccine for hepatitis C. Okay, so when we talk about hepatitis B, the vaccine is possible, but we don't have okay, so it's to prevent you from get but if we talk about vaccination, you need to know the levels as well, okay? Because you know now we have three-dose injection for viral hepatitis B, but after quite some time the level will be reduced, and when the level is reduced, actually it's not really effective anymore. That's why when the patient say they have a vaccination, you need to know what are the current level, if the patient need booster or so on. But as far as I know, this is not happening in public health care and so on. It will be in a private setting immediately. Okay, but if you talk about in a child to prevent a vertical transmission, there are two types of immunization. The first one is the vaccination, where we try to train the immune system to produce antibody toward these antigens, but we also give the active immunization. That means we give the immunoglobulin, the ready-made antibodies against the virus as well. Okay, so in child we get two, active and passive immunization, and supposedly that will prevent the vertical transmission. Okay.
Thank you, Doctor.
All right. Any other question? If no question, we move.
Sorry, Doctor. For the hepatitis, so our aim of treatment is to convert into to eradicate the virus in the body. So tapi is there a difference between treatment for acute and chronic viral hepatitis ke just the same antiviral lah?
No, okay. First of all, in chronic viral hepatitis C is a clear cut. Okay, the aim of treatments to clear the virus from the body is very clear cut, and we have the effective medication to do that. Okay, so there's no question at all. But when you say about acute hepatitis B or C, there is a chance that they will have a spontaneous clearance. So we don't treat acute viral hepatitis B and C, we only treat a chronic viral hepatitis B and C. Okay? B, maybe we treat is a life-threatening disease, but mainly we don't treat unless it's a chronic. Okay, but for chronic viral hepatitis B, the aim of the treatment is not clearly stated, okay, because we don't have effective medication. These tenofovir or entecavir may reduce the viral load, may slow the progression for the patient to develop cirrhosis, but the efficiency for patient we treated with tenofovir to get S antigen seroconversion to surface antibody is very low, and you know, we don't have a cure for chronic viral hepatitis B. Okay, we have a cure for chronic viral hepatitis B, C, but we don't have a cure for chronic viral hepatitis B. So what we do is try to control the inflammations, to minimize the inflammation, and to prevent cirrhosis, or if patient have cirrhosis, to slow down the cirrhosis. Okay, but let's say in the future, if we have effective medication like viral hepatitis C, and they will change. We just want to make sure everybody have no more virus. Okay, but at the moment we don't have that kind of treatments. All right.
All right. Thank you, Dr. Nik.
All right. Okay, fine. So, okay, I think that if you have no questions, we just move forward. We talk about chronic liver disease. Okay, we talk about chronic liver disease. When you talk about liver disease, you actually have to understand the spectrum of liver disease. Okay, the liver disease you can have hepatitis. Okay, the hepatitis is not a diagnosis. Hepatitis is a condition of the liver. Is implied that the patient have inflammation of the liver. Okay, so people with acute hepatitis, they can resolve. Okay, they have acute hepatitis. After a few days, the hepatitis resolve, and that's it. Okay, but some patients with acute hepatitis, they can progress. And if they progress very, very fast, they can develop acute liver failure. Okay, when you talk about acute liver failure, the definition is that patient with a liver injury manifested as a jaundice. The patient need to have a liver dysfunction, synthetic liver dysfunction. Okay, meaning the INR more than 1.5 or proton beam time more than 3 seconds. And the patient need to have hepatic encephalopathy. Okay, if you meet these 3 criteria, that means the patient have acute liver failure. But if patient don't meet this criteria, the patient have liver injury, jaundice, but the patient have a synthetic dysfunction but no hepatic encephalopathy. So that means the patient have acute severe hepatitis but not really acute liver failure. And these 2 entities is a very, very important, because in acute liver failure is implicate a poor prognosis, meaning that if we are not treated, the patient not treated, the mortality rate is more than 50%. If not treated with a liver transplant and so on. Okay, why patient with acute severe hepatitis, even though the bilirubin is sky high, the ALT is sky high, is still considered as a good prognosis, meaning that majority of this patient will recover from this acute episode. Okay, and there is a third pathway that can happen. The patient with acute hepatitis can go to a chronic hepatitis, meaning the inflammation can last for more than 6 months. Okay, so you need to know the disease of the liver, and you need to know the spectrum of the liver disease as well. Okay, all right, and for the patient with acute hepatitis, the cause including chronic virus hepatitis A, hepatitis B, hepatitis D, hepatitis E. It could be autoimmune disease like autoimmune hepatitis type 1, type 2, type C, primary biliary cirrhosis, PSC. It could be due to fatty liver disease. It could be due to alcoholic liver disease. It can be due to medications. It can be due to hemochromatosis. It can be to alpha-1 antitrypsin deficiency. It can be due to Wilson disease. So the differential diagnoses are very, very big. Okay, but there are certain diseases that can cause acute liver failure compared to another. For example, acute viral hepatitis A, they can progress to acute liver failure. But for for acute viral hepatitis C, they don't progress to acute liver failures. Okay, there are diseases that usually progress to chronic stage. There are diseases not progress to chronic stage. For example, chronic virus hepatitis A, they don't progress to chronic stage. You don't have a chronic virus hepatitis A. Okay, but B and C, they can progress to chronic stage. Okay, so different disease, they have different pathway in terms of the disease progressions. Okay, but we won't be able to go through individual disease. Okay, so just a broad idea what are the spectrum of a chronic liver disease. All right, so when the patient, acute liver failure and result acute hepatitis will end that way lah. Either patient will survive or recover. Okay, but for a chronic hepatitis, it can progress further. Okay, it can progress to fibrosis. There is a grade 1 fibrosis, grade 2 fibrosis, grade 3 fibrosis, and finally a grade 4 fibrosis, which is the liver cirrhosis. Okay, when we talk about grade 4 fibrosis, they are bridging fibrosis. Okay, bridging fibrosis with a nodular regeneration. That is the meaning of liver cirrhosis. Okay, all right. But in the recent years, there are also another spectrum of liver disease that will be more recognized. Okay, we call it acute on chronic liver failures. Okay, so I don't want to confuse you with the acute on chronic liver failures, because even the American group, the European group, and the Asian Pacific group, there is no agreed definition for acute on chronic liver failure. Okay, they still fighting with each other. One group say acute on chronic liver failure is this, another group say it's that. Okay, but there is emerging topic, emerging area of interest that we will see more and more in the next few years. Okay, if you're interested, you can read about that. Okay, now for acute hepatitis, nothing much I want to say. For acute liver failure, okay, so acute liver failures. Okay, for acute liver failures, I want to talk about the etiologies. Okay, the etiology, two common cause would be medications and autoimmune disease, medication, and also viral hepatitis. Probably the three etiologies lah, and there is many more. Okay, so when you talk about acute liver failure, straight away I say a poor prognosis. Straight away we talk about liver transplant. Okay, in liver failure, we have to talk about liver transplant. And how do you know if a patient is indicated for liver transplant or not?
We have the criteria.
Okay.
Name schemes criteria, but I don't remember the detail.
Is it Milan criteria?
Okay, there is a King College criteria, but also another thing that we use a MAP criteria. Okay, MAP criteria. Okay, model of end-stage liver disease. Okay, MELD or MELD sodium criteria. Okay, all right. So in terms of the etiology, in Western countries, maybe paracetamol. Okay, paracetamol. Now again, you see people with paracetamol come to the hospital and develop acute liver failures. Okay, so that's why in King College criteria they have criteria for paracetamol acute liver failure and non-paracetamol acute liver failures. Okay, because that's a common condition they see there. But in Malaysia setting, we don't see that much of a paracetamol overdose. Okay. If you when you talk about daily drug-induced liver injuries, you have to talk about 3 possible mechanisms that these drug can cause liver injuries. Okay, the paracetamol is a classic example of overdose. Okay, if you remember about your pharmacological lectures during clinical, they talk about therapeutic windows. They talk about toxic windows. Toxic windows. Okay, there are drugs where the therapeutic windows and the toxic window are very close, like warfarin. They need close monitoring because the toxic window are very, very close and the therapeutic window are very small. Okay. But the thing is that if you talk about drug overdose that cause liver failure, they don't happen if you get you take a regular dose. For example, you take a paracetamol 1 gram QID, you won't get a paracetamol overdose. Okay, unless of course you have underlying problem lah yang menyebabkan liver paracetamol is not coming down. Okay, but usually we're not going to see the patient with acute liver failure taking due to paracetamol taking a regular dose of paracetamol. Okay, they need to be in the toxic dose. Okay, for paracetamol is 20 tablets. Okay, about 10 grams. Okay, that's why if you go to the pharmacies, they don't send, don't give you a 20 tablet of paracetamol in the pack. Okay, because they don't want people to take a whole of that and get an overdose. Okay, but there's also another mechanism we call the idiosyncratic drug reaction. Okay, and this one is unpredictable. It can happen at any dose. You give a co-amoxicillin 625 milligrams 3 times a day. It's a normal dose, but the patient still can develop idiosyncratic drug reaction from co-amoxicillin. Okay, even though you give a right duration on 7 days, the patient can still have it. Okay, so because of unpredictable natures of this, it's a very, very difficult to treat. Okay, and the last mechanism is hypersensitivities. Okay, like your allergy, allergic reaction, you can get the patient with hypersensitivities in the liver due to medication. Okay, like a DRESS syndrome. Okay, all right. All right, so I talk a bit about liver cirrhosis. Okay, about liver cirrhosis, because liver cirrhosis we have no cure. Okay, liver cirrhosis, one, you have the scarring of the liver, fibrosis. 4, there is it's not reversal. Okay, so when you talk about liver cirrhosis, you need to know about the prognosis. Stratify the liver cirrhosis. You can use the Child-Pugh classification A, B, and C. When you say about Child-Pugh C, it's like a patient having a cancer. Okay, 50% will die within a year. Okay, but if you have child A, usually life expectancy 15 to 20 years. Okay, so not bad. Okay. All right. So tell me, what are the complications of liver cirrhosis?
For the complication of liver cirrhosis, first, the complication in the liver itself, it will lead to hepatic failure. So hepatic failure will further lead to coagulopathy, encephalopathy, and also hypoalbuminemia state, which okay. And then for another complication is portal hypertension that lead to splenomegaly and also esophageal varices.
Okay, fine. So, okay, so this is very important because you see liver cirrhosis all the time. So, okay, when you talk about liver cirrhosis, you need to look straight away, look at the 5 complications of liver cirrhosis. Number 1, as you mentioned, a portal hypertension that will lead to esophageal varices. But another complication of portal hypertension is the ascites. Okay, and then we need to talk about Hepatorenal Syndrome, we need to talk about hepatic encephalopathy, and we need to talk about Hepatocellular carcinoma. Okay, so cirrhotic patient, I want to know why this patient have cirrhosis, what are the etiology, and I want to know what are the 5 complications of liver cirrhosis. The patient have developed these complications or not. All right. So we start with the hepatic encephalopathy first. Okay, so hepatic encephalopathy, how do you diagnose hepatic encephalopathy?
We diagnose it by clinically.
Yeah, you're right. Keep going.
Example, the patient has the symptoms includes change of behavior and such as confusion, dizziness, and as well as sleep disturbance, and there are actually stages for the hepatic encephalopathy as well.
Yeah, okay, you are right. Okay, the hepatic encephalopathy usually are clinical diagnosis. You have stage 1, 2, 3, and 4, and you also can check the hepatic flag. Okay, hepatic flag will indicate hepatic encephalopathy, and there is some tests we can do as well. If you Google a trail test, okay, a trail test to see your cognitive functions, you can ask a patient to draw a 5-pointed star for constructional assessment and so on. Okay, so there are a few ways for you to get to diagnose hepatic encephalopathy, but mainly clinical. The ammonia level is not sensitive, or I never send an ammonia level to diagnose hepatic encephalopathy. Okay, how do you treat this? You treat this by moving the bowel, because we think that the toxic is originated from the bowel. Okay, if you move the bowel, you prevent accumulation of the toxic in the bowel and reduce the hepatic encephalopathies. Okay, so you remember from your preclinical stage that blood supply to the liver have 2. One is hepatic artery and second is portal venous system. Okay, the portal venous system is rich with nutrition because it take all nutrition absorbed from the bowel. Okay, it goes to the portal vein and then you go to the liver for storage. But it's also rich with toxic. Okay, it's rich with the toxic, and then you go to the liver, and the liver will filter and metabolize, detoxificate this toxic, and then we are well. Okay, but when liver is not functioning, this toxic is not filtered in the liver, it go to the bloodstream, and then develop hepatic Okay, so you move the bowel. What you're gonna do? You're gonna give a patient leg to loose, and your aim is patient to move bowel motion 2 to 3 times a day. Okay, there's also antibiotics that being proposed in treatment of hepatic encephalopathy, again to reduce the microbiota in the bowel, and the treatment is using rifaximin. Okay, antibiotic that not absorbed in the system, but a topical antibiotic, rifaximin. But as far as the treatment goes, for hepatic encephalopathy, it's only proven in liver cirrhosis, and decompensated liver cirrhosis. In acute liver failure, there is no role of doing this thing. Rifaximin or lactulose, they found there is no beneficial. Okay, and then we have esophageal varices. So we talked in detail about esophageal varices earlier on. I don't think that we need to repeat about that. And then we have ascites. Okay. All right, so how are you going to diagnose ascites?
By clinical examination, we can do shifting dullness and also fluid thrill.
Okay, fine. So what else you want to do?
And then we can do the peritoneal fluid analysis, and to look for the serum. Okay, SAAG. Serum albumin gradient. Okay. To further differentiate either it is transudative or exudative.
Okay, fine. So, okay, you are right. First, you need to establish there is ascites. Ascites you can elicit clinically. If there is a very low volume, maybe ultrasound will be helpful. But another thing that you need to know is that what causing the ascites. Okay, the ascites is not exclusive due to a liver disease alone. Okay, we are not talking about exudate and transudate anymore in the ascites. In the pleural fluid analysis, we talk about that, but not longer in ascites. Okay, in ascites, we talk about set gradient, as you say, and the function of set gradient is to determine if the cause is a portal cause or is non-portal cause. Okay, when we talk about portal cause of ascites, we talk about what you mentioned early on about pre-liver, liver, and post-liver cause. Okay, you need to consider that. Okay, but when you talk about a non-portal cause, you talk about peritoneal carcinomatosis, intestinal tuberculosis, a nephrotic syndrome, etc., etc. Okay, so you need to know the use of set gradient, how you're going to interpret the set gradient, what are the causes of portal cause, what are the causes of non-portal cause, and how to clinician diagnosis for each differential. All right.
So from the set analysis, if it is less than 1.1, so that will be the non-portal, doctor.
Yes. Okay. Unique ascites is not a diagnosis. Okay, hepatitis is not a diagnosis. Okay, when you talk about diagnosis, you say a underlying condition. Okay, all right. So there are a few investigations you need to do for pleural fluid analysis, not just set gradient, but you can send a cytology as well, because it actually have a quite high yield to diagnose peritoneal carcinomatosis. Okay, the fluid sample you can send for TB as well. Alpha classified bacilla and TB culture, etc. All right, focusing on liver cirrhosis again, the ascites. How are you going to treat? How are you going to manage patients with ascites?
we have non-pharmacological management. So for non-pharmaco, we can restrict the fluid and then restrict the salt, and then for pharmacology, we can give diuretics and diuretics. Also, if kalau patient develop the second punya complication SPP, we can give antibiotics. For certain patient, if it is cross ascites, we may consider of the large volume paracentesis, but we have to give albumin infusion. I think that's all that I can think right now.
Okay, fine, very good. Okay, I think this is the way for you to answer. Okay, you need to familiarize yourself. Okay, the simplest thing, and then you go to more and more complicated things. Okay, so I agree with you that number one is non-pharmacological management, salt restrictions. Okay, not a fluid restriction. Salt restrictions is most important thing in the management of the ascites. And basically, you say that the patient cannot eat the additional salt. Kalau masak tu apa, jangan letak garam tambahan. Okay, as it is. Okay, usually that will be sufficient, and hoping that we improve the ascites. And second is diuretic. Okay, when you talk about diuretic, there are many options. You have a loop diuretic like furosemide. You have a potassium-sparing diuretic like spironolactone. Okay, and then you also have options of doing a large volume paracentesis. Okay, the large volume paracentesis is indicated if patient have respiratory involvement, because of ascites, patient cannot breathe. Okay, and then you have to do a large volume paracentesis. What is a large volume paracentesis? It meaning you tend to dry. Okay, you stick the needles until it dry. Okay, 10 liters, 15 liters, and you don't need to be worried about this. Okay, because there are studies about this. If you actually do a large volume paracentesis, in average, it's only reduced about 5 millimeter mercury of UMAP. Okay, you won't get a profound hypotension by removing 10-15 liters of ascitic fluid. But what you have to do is that if you want to do a large volume paracentesis, you need to replace the albumin. Okay, so every 1 liter of ascitic fluid drain, you have to replace with 8 grams of 20% human albumin. Okay, if you don't do this, the patient have high risk to get Hepatorenal Syndrome. All right. All right. So large volume paracentesis. Yeah.
Oh, sorry. I just want to ask whether we have the option of yang clonidine and midodrine. Do we give that in
what say?
Clonidine and midodrine.
I don't know. I don't do that.
All right. Okay.
I don't do that. Okay. Do we have midodrine?
I don't know. I never see that, but I just read in the textbook. So I just wonder because I never seen prescription. Yeah.
I don't know we have a midodrine here or not. Usually I don't do. Okay, I don't see in the literature the use of that as well. Okay, in the guidelines there's no mention of that as well. All right. Okay, you stop until that. Okay, but you should keep going because you know this is the same problem as esophageal variant, isn't it? The problem is the portal hypertension, and you know in esophageal variant we discussed earlier on, we can consider tips for treatments of resistant OV bleeding. Okay, it's the same as a patient with the resistant ascites, we can consider tips as well. Okay, but tip is contraindicated for people with hepatic encephalopathy. Okay, why? Because you know already that portal vein is rich with the toxic. Okay, now you want to bypass the liver and get the toxic unfiltered to the systemic circulation. That may worse the hepatic encephalopathy. Okay, so TIP is contraindicated for patient with hepatic encephalopathy. Okay, but the TIP is only a bridging therapy. It's not a definite therapy. So what is the definite therapy for people with resistant ascites?
Peritoneovenation?
No.
Liver transplantation.
Yeah, okay, liver transplant. Okay, ultimately, patient need a liver transplant. Okay, but the issue of liver transplant in Malaysia to get a coronary donor, etc., etc. You know, so we don't do much of liver transplant. But now, have started doing living donor liver transplant. Okay, usually we do this for children, the living donor liver transplant. But for adult living donor liver transplant, I think have a few cases lying out as well now. Okay, so maybe that would be the way for the futures. You know, the sibling donate the liver to the patients, father to son, etc., etc. All right, that will be ascites, and then you have ascites. Another thing, ascites is a spontaneous bacterial peritonitis. Okay, ascites can get infected. How do you diagnose SBP? You need to do a pleural fluid analysis. What you look at the polymorph. Okay, more than 250 per millimeter square. Okay, that will be diagnostic. You don't need a culture, you don't need a gram stain, you need to look at the polymorph more than 250. Treatment of SBP will be antibiotics and also albumin infusion. Why albumin infusion? Because when the patient gets SBP, they usually will develop Hepatorenal Syndrome as well. Okay, what else? We don't talk about Hepatorenal Syndrome, okay? So Hepatorenal Syndrome is a very difficult condition to diagnose because it's a diagnosis of exclusions. You have to exclude the parenchyma disease, you need to exclude all the post-obstructive uropathy, you need to exclude sepsis, you need to exclude hypovolemia, in order for you to diagnose functional AKI. Okay, you need to exclude everything. Okay, you need to do ultrasound, you need to do urine dipstick, you need to do everything. And also you need to give a trial of fluid expander as well by giving albumin 1 gram per kilogram for 2 days. Okay, if a patient responds to albumin infusion or fluid expander, that means it's most likely hypovolemic. Okay, if a patient not responsive to fluid responder, and then you talk about Hepatorenal Syndrome. And of course, a nephrotoxic drug should be stopped as well in order for you to make a diagnosis. Okay, so if you want to know how to make diagnosis of Hepatorenal Syndrome, you can read a criteria published by International Ascites Club Group. Okay, that they give you a definition how to diagnose Hepatorenal Syndrome. The treatment option including start patient on telepressing or no adrenaline with albumin infusion. Okay, but usually if they develop type 1 Hepatorenal Syndrome, the mortality rate is very high. It's more than 90% of this. Okay, even if they develop type 2 Hepatorenal Syndrome, the prognosis is not good. Okay, and there's not really a treatment that good enough to treat the Hepatorenal Syndrome. Most of the treatment is to bridging patient for a liver transplant. Okay, and lastly, we're going to talk about Hepatocellular carcinoma. Okay, so for Hepatorenal carcinoma, you need to read about Barcelona Clinic for Liver Cancer. Okay, you need to read about Barcelona Clinic for Liver Cancer criteria to diagnose and to manage hepatocellular carcinoma. Okay, liver cirrhosis itself is a risk factors for development of HCC, hepatocellular carcinoma. Okay, so for patient with liver cirrhosis, you have to do a surveillance 6 monthly alpha-cytoprotein and ultrasound liver. If patient have a liver lesion, you have to do a CT liver, and the diagnosis is based on the Barcelona Clinic liver cancer criteria how to manage. Okay, so I'm not going to talk in details. If you are interested, you can read about it. All right, any question you want to ask me? Here. All right, any question about cirrhosis?
Doctor, is there a role in prophylaxis for spontaneous bacterial peritonitis?
Say again.
Prophylaxis antibiotic for spontaneous bacterial peritonitis. Is there any?
Usually not, unless a patient have OV bleeding. We give ivacaftorasone prophylaxis because we know that in this group they are higher risk to get a spontaneous bacterial peritonitis. But other than that, usually we don't give prophylaxis antibiotic. But if a patient have one episode of SBP, we can consider a long-term and prophylaxis antibiotic for this group. Okay, they have SBP and then to prevent a second SBP. Okay, usually we can give vanilla like ciproxine.
Doctor, may I ask, just for the confirmation, regarding the management of acute upper GI bleeding when we have the two pathway, either going into the variceal or the non-variceal, meaning that we cannot bombard both of them in the case of diagnostic uncertainty. Let's say that we don't do the scope yet, so can we like cover for both of those pathology?
Okay, for patient with no stigmata or any history or any sign and symptom to severe chronic liver disease, we just treat them empirically as peptic ulcer disease. But when patient have a stigmata of chronic liver disease, you don't know. Okay, even people with liver cirrhosis can have a peptic ulcer, right? Okay, so in this group, I usually cover for both PPI and also telepressin. Okay, but if no stigmata chronic liver disease, just peptic ulcer disease.
All right, thank you, Doctor.
Okay, any other questions? Okay, any questions about gastroenterology and hepatology? Anything you want to ask? Okay, fine. So it looks like you know everything now. Very, very good. So I think that's all for today. You must be very, very tired, and I think some of you behind the screen already sleeping because I cannot hear your voice at all in the last 3 hours. Okay, keep quiet. Okay, anyway, thank you very much for listening. I think we have some good discussion today. Hopefully it will be beneficial for you. If you have any more questions or any topic to discuss, you can let me know. Otherwise, I see you again in the next sessions, tutorials or bedside teaching, or if you don't have any class with me, and then I see you again during your exam. All right? Okay, thank you very much.
Thank you, Doctor.
Okay.
Thank you, Doctor.
Thank you, Doctor. Thank you very much.
Thank you, Doctor.
Thank you, Doctor.
Thank you.